fantastic. So it's quite helpful. So I'm a doctor, I'm a patient, and I also love education. And it's always quite helpful when you do any learning session to know what the person teaching you is intending you to take away at the end of the session. I've done a lovely list here, but there's two things really, from my point of view, with ME/CFS. One is recognition, and the second one is support. And if you learn nothing else today than recognition and support for these patients, then I think it will be a fantastic take-home message. But in terms of more details, ME/CFS is a neurological disease and it's diagnosed based on history. A key feature is post-exertional symptom exacerbation or post-exertional malaise. And that means that in the hours or days after doing anything physical or mental or even emotional, which puts the patient beyond their normal energy envelope or capacity, they will feel sicker, and they'll often get multi-system symptoms, sore throats, headaches, fatigue, crushing fatigue. And that is cardinal to this disease. It's often not recognised in the early stages, and often the exertion can be so trivial, such as brushing your teeth or climbing a flight of stairs, that the person is almost in a perpetual state of post-exertional symptom exacerbation. This is neither a diagnosis of exclusion nor an exclusive diagnosis. Make the diagnosis and keep looking. So for a long time, this was thought to be medically unexplained, and you had to exclude every other medical condition before making this diagnosis. However, it's becoming clear that there is a pattern of symptoms that can be easily recognised and a diagnosis can be made. And patients who are given an earlier diagnosis and the right advice to rest and pace are seeming to do better from anecdotal and patient evidence. Many patients with ME/CFS and many patients with long COVID now have multiple other comorbidities and new diagnoses, including postural tachycardia, mast cell activation. Some have connective tissue disorders or personal or family history of autoimmune disease. So keep looking, ask all the right questions, do a full system inquiry. Once a diagnosis has been made, don't forget to keep looking, keep an eye on these patients in the months and years after diagnosis and make sure they're not developing anything new. ME/CFS has a major impact on the quality of life of patients and a major impact on the quality of life of their family members. And it also has an impact on their workplace and their social support system. Some patients are children of elderly relatives who need care and they're too unwell to care for their parents. Some patients are parents and they have young children who are their dependents, and this can cause major repercussions. The key to good care is recognition and support. So I'm going to go through the epidemiology, nomenclature, definition, differential diagnosis, management, and summary. But what's most important is realizing that behind this is true patient story. And I'm going to share my story, and also very kindly, a couple of doctors with long COVID have offered to share their story and some of their photos with you today. So I have experienced being in an ME/CFS patient's shoes. And before I had ME/CFS, I didn't know what the disease was. Despite it affecting millions of people worldwide, many clinicians lack the knowledge to appropriately diagnose ME/CFS. Clinical guidance to date has been scarce, obsolete, or potentially harmful. And in the US, up to 91% of patients remain undiagnosed. Those diagnosed often receive inappropriate treatment, and recognition of this disease is increasingly important because of after acute COVID-19, a significant percentage of people remain ill for many months with an illness very similar to ME/CFS. This was published just last month, and it's a very good paper, quite short summary of the disease, management, and definition, and I would highly recommend it. I'm also going to share with you, hopefully now, a short video. This will test my technical skills, see if I've learned how to do this properly.
You may need to reshare, Dr. Muirhead, and just make sure that you choose the screen.
Okay, I'll stop sharing, reshare. Thank you, Andy. I knew I'd forget. This is a problem with ME/CFS. You have a bit of a working memory issue. Right, let me share this again. Oh, and I forgot to share my sound. Let's go back. Right, share sound. Now share. With a bit of luck, this will work now.
Suddenly, I couldn't do a fraction of the things I could do before. My name is Dr. Nina Muirhead, and I'm a dermatology surgeon. I work for the NHS, and I'm also a patient with ME, and I've been ill since September 2016. It took about 10 months from my first symptoms to realising I had ME, during which time I saw 13 different doctors. It was horrendous. It was almost like being in a semi-coma. All my very basic bodily functions were struggling, and my capacity to do anything like read or watch TV was zero. I spent many hours a day sleeping, and I spent 5 or 6 hours a day just staring at the walls or ceiling. At my worst, I had to actually go and be cared for by my 2 retired parents. I was too ill to live in the same house as my 2 young children because they made too much noise, and I couldn't cope with the noise, and I couldn't cope with demand on my energy. I couldn't even pick up my daughter, who was only 1 year old at the time. And my parents nursed me, they made all my meals. I was like a toddler. I had to have frequent small snacks and regular naps. And it was all consuming for them. I returned home 4 months later in a wheelchair, and I still then struggled for another 18 months to get back to work. Before I had ME, I actually had very little time for patients with ME. I didn't really understand the illness. It was very non-specific. It wasn't taught very well at medical school. And because I couldn't categorise it or treat it particularly, I pretty much ignored that as a differential diagnosis, and looking back, I've probably missed quite a lot of patients with ME. Psychiatry has caused a lot of delays and damage in the field of ME. There have been various theories that patients with ME are otherwise healthy and they are just excessively resting, and that's causing all their symptoms. There are also theories that patients are frightened to exercise and it's their fear avoidance or concentrating on symptoms that are perpetuating their illness or even causing their illness. And I think a lot of work needs to be done to undo all of that harm that the belief of the healthcare practitioner that the patient's making it up has caused.
So thanks to the Times for producing that very powerful video on my story, which I will continue to share now, hopefully. Can everybody still hear me?
Yes.
Yeah, great. Okay, fantastic. So when doctors and healthcare professionals can see what's going wrong with the patient visibly, it's very easy to know how to manage them in a caring and compassionate way. but it does tend to get a little bit lost in translation when the patient has an invisible illness and the patient in front of you looks fairly normal. I've just shared my short video, but my symptom list was very long. I'm normally a well-fit person, but I had every system involved at all different levels. So I had diarrhea, vomiting, tinnitus, light sensitivity, dizziness, chest pain, shortness of breath, problems with breathing, getting my breath, difficulty concentrating to watch TV, reading, multitasking. I would get headaches, really severe facial pain, pain in the top of my mouth, joint pains, muscle aches, spasms, difficulty getting dressed, severe pain in the back of my neck, difficulty showering. I had to sit down in the shower. I found it hard to eat and digest food when I was at my worst, and also difficulty regulating temperature, feeling hot and cold. I had glandular fever in 2016, and despite being unwell with viral symptoms, I actually pushed on through like anyone would with a normal cough or cold. Busy mum, busy doctor, carried on working, carried on exercising and looking after my family. But there was definitely something wrong. I was starting to get all these multi-system symptoms and ignoring them. But I did end up having to have a few investigations to try and find out why I was coughing up blood clots for several days and why I was having difficulty with chest pain. Eventually, I was diagnosed with a glandular fever in April 2017 and also POTS in June, July 2017. And it was a nurse who was doing my OBS who picked up my postural tachycardia, even from sitting, from lying to sitting. From lying down, my heart rate was 69. And on sitting upright in the bed, my heart rate was 101. I thought I had a brain tumor or MS because of all the neurological symptoms. But it turned out that this was actually ME/CFS. For much of 2017 and 18, I was mainly bedbound and required a lot of help and care from both my parents and my husband. My husband spent 15 months caring for me and the children. And I have been since then trying to get back to my normal NHS day job. So I now work half-time as a dermatology surgeon for the NHS, and it's my dream job, and I'm very pleased to be back. As a patient, I had quite a different experience of this illness to what I thought about it as a doctor before I got sick. And what was really interesting is that most of the comments that colleagues said to me were slightly dismissive. I'm sure you'll get your strength up, or can't you come along for a blood test in person? I said I would be sick for 2 or 3 weeks recovering from just attending and sitting and waiting for phlebotomy. But they couldn't really understand that I was really that ill. I was even told that my symptoms were because I was deconditioned and that I needed a social life. I did have some very understanding doctors and some incredibly helpful colleagues. My GP made a diagnosis, looked at me in a very caring, compassionate, believing way and said, "You poor thing, this must be dreadful for you. I will support you in any way possible." And she suggested the wheelchair, which was enabling rather than disabling. And she gave me vitamin B12, antivirals under the sort of advice of an immunologist. And she was incredibly compassionate. And that helped me so much. And it gave me hope. I've promised to cover long COVID. Now, I really must stress here that long COVID is currently lots of different things at the moment. There's patients with organ involvement, patients with chronic lung damage, lots of different presentations. There are some patients who've got post-traumatic stress. There are patients who have clotting difficulties. So this is a big set of lots of illnesses. But what I'm talking about is the subset, and at least a good subset are meeting the diagnostic criteria for ME/CFS. And some are finding help and support from the management that ME/CFS patients have advised, including rest, pacing, POTS medication, antihistamines. And what has become apparent is that both ME/CFS and long COVID are underestimated and frequently misunderstood by medical professionals. This is not anxiety manifesting in bodily symptoms. This is bodily symptoms due to problems at a cellular level, which can then make the person quite anxious, particularly if they are presenting to healthcare professionals and not being believed. So Sean is a doctor, 33-year-old palliative medicine doctor, working in a community and hospice during the first wave. So he feels as though he probably had quite a high viral load. He started in March 2020 with acute symptoms, including fever, anosmia, fatigue, myalgia, headache, dry cough. He only took a week off work. And in fact, I think he did a clinic from home during that week and pushed himself to try and get back to normal. Even in the early stages of returning to work, he was put on 48-hour on calls, but he kept on pushing through, and he returned to work for a good 6 months or so. He was convinced he was getting better. His cough started settling, his sense of smell came back, but he knew he wasn't 100%. He was needing to go to bed earlier, struggling to do anything at all on his days off. After on calls, he would feel wiped out, beaten up, really exhausted. This is him on the sofa, looking quite pale and unwell. He was exhausted on waking up. He was lightheaded on standing, couldn't concentrate on reading, and struggling even to make it to the corner shop. And this is a fit young man who loves travel and is a doctor. Asad, another colleague, a 45-year-old respiratory consultant. He was working frontline and is also fighting to improve PPE and to acknowledge that there were problems with PPE supply. He was fit, going to the gym 3 times a week, cycling, swimming, married to a GP with 2 primary school age children. We're busy, healthy, normal people, and then suddenly got a virus and suddenly couldn't do anything. Asad had all the symptoms that I had, and I even had this facial swelling as well. In November 2020, started with a low-grade temperature, sleepiness, nausea, was positive on the SARS-CoV RNA test, took a month off work because he was very fatigued, started returning to work, just doing a couple of hours a day, and then suddenly massive onset of post-exertional confusion, drowsiness, chest pain, palpitations, pain in every joint, polyuria, nocturia, rashes involving his head and neck. It does make you feel like you're going mad when you're getting all these symptoms bombarding you from all the different systems. He also had the tachycardia, went up to 105 with postural exaggeration, at times up to 160. Impaired cognition, ended up going to hospital 3 times, chest pains and desaturating. He had a couple of courses of steroids, which really did help, suggesting there is an inflammatory component to this illness. He also had worsening after his Pfizer. In terms of how colleagues have treated us, it's really quite variable. Some are supportive, others are also under strain and stress and really cannot share that burden of of clinical absence from the workplace. I started looking through these and thinking, do they sound positive or do they sound negative? But actually, it's how the person feels when they're receiving these comments. If you are so sick, you can barely walk up a flight of stairs or have a conversation or digest your dinner, and a colleague is saying, well, your clinic patients, they're all waiting for you. They might have been encouraging you to try and get back to it, but if you're so sick that you physically can't, then it can be quite damaging and distressing to hear that from a colleague. So be very careful how you phrase what you say to patients before you understand really what their level of coping is and their severity of their illness is. There are, in fact, 1.2k doctors now part of the long COVID Facebook group. So this is not a rare problem. We're getting increasing numbers of healthcare professionals across the board. A lot of nurses have been affected as well. And I've been in touch with OTs, physios, psychologists. Everybody is nutritionists who've had such healthy diets, and then they've got either ME/CFS or long COVID. This is all the same thing about the relationship between yourself as a healthcare professional and the patient. It involves trust and respect. And part of the problem with the lack of education in this sector about this disease has been a breakdown of the trust and respect. And there has even been the development of the idea of a framework to suggest how, when the patient and the practitioner don't agree, how to deal with that. Well, actually, if you're a healthcare practitioner and you really want to help your patient, then I think it's really important to really try to understand and empathize with what they're going through, rather than thinking, oh, well, they're probably making it up or they're probably exaggerating their symptoms, because 9 out of 10 times the patient will be telling the truth. There is no motivation to be ill. There's nothing to gain from being sick. It's horrible. So the sooner you can sort of recognize that, the better you can build on that relationship and you can truly help the patient. So take a good social history and get the medical information and provide information. And there are lots of, well, Hope for ME and Fibro is a fantastic charity and has a lot of educational resources for both patients and professionals. GPs can often, well, all doctors and healthcare professionals can often be wary of what to do about diagnosing the patient. And if you're not a doctor, you can still say, please go to your doctor because I think you might have this condition. We've all got a duty of care. So this is information gathered by NICE to see what GP views were beforehand. And they were saying, well, I don't really know what, there's a treatment. I think it's a label, but then what do you do afterwards? It's unhelpful. It's just not very high on my differential diagnosis. That's something that was true of myself before I got sick. And the label is negative in the sense that messages people get from it is that you have to just wait around and get better and there's nothing you can do. Well, actually, as a patient, it's a very, very difficult job to stay inside your energy envelope, and often patients overdo it. And one of the biggest pieces of advice that my GP said to me very early on is, whatever you think you can do half of that. And then very, very slowly, your body can use the energy you've got left to start recovering. And that was incredibly helpful advice. And I think even rather than say, just wait around and get better, giving the patient some role to try and help manage their energy within their envelope is incredibly helpful. However, some patients are too sick to have patient-led care, and they really do need care and input from the community and relatives. Sitting in the consultation can be really stressful for a patient, especially when faced with a professional who has an idea that they're deconditioned or demotivated. This patient's thinking, how do I tell this healthcare professional all my symptoms when there are so many? I'll forget what I'm saying halfway through. I won't understand what he's saying. The lights are so bright, I feel dizzy and nauseous. He'll think I'm a hypochondriac and tell me just to stay positive and get some exercise. Patients are experts at this. We've heard it before. We've tried it ourselves. By the time we go and see a healthcare professional about problems sleeping, we have tried every trick on the internet. The dark light, the dark nights, the removal of screens, the eye patches, we've tried it all. We're desperate to get better. So to be told very practical, basic things shows that the professional doesn't know how ill we really are. So there is quite a gap in the knowledge. And it's leading to some issues in the encounter that we could perhaps maybe work around. So either they don't agree and everybody leaves a bit uncomfortable from the interaction, or there's some sort of compromise. The doctor says, well, if you try and do a little bit more each day, then, or, you know, maybe just try just 5 minutes of walking or 2 minutes, you know, just to do a bit more. But the patient's saying, no, I can't do any more than I'm already doing. Neither end up satisfied. Or worse, the health or social care professional imposes their own narrative on the patient that, oh, well, they might be deconditioned or depressed or anxious, and maybe if they sort of got some support for that, their disease would go away. And that has been shown, unfortunately, to be harming patients.
Well, I've had people say things like, oh, you must be attention seeking, or you must hate school, or you're just lazy, or you just don't like to do things, or you're depressed. People have said it's a psychological thing as opposed to a, you know, a real physiological illness. The best way to kind of describe ME would be like a phone battery that's never been charged, like never fully charged. It's only half charged, and that drains really quickly. Whatever you do, you get a low immune system. You get very extremely exhausted, and are a lot of pain. You know, muscular headaches, joints, even things like getting down the stairs are really difficult for me. It takes can take me a long time. I have to have a minimum of 12 hours sleep, otherwise I can't do anything. It would be very difficult for you to tell that I'm, you know, very ill because I don't look ill. And my mother really has to pull me out, lift me out of bed because I can't get out of bed in the morning. And she has to dress me some mornings. I got ill at 14, and at first I started getting tired and started noticing that I get to the top of the stairs. I used to run up and down the stairs, and I'd get to the top of the stairs and suddenly be out of breath. And then I started getting lumps in the back of my head and started waking up with my glands swollen. The doctor started saying, you know, we know what teenagers are like. What are you talking about? That's not a, you know, we know how lazy teenagers can be. We'll keep sending you things, but it really doesn't look like there's anything wrong. And they started doubting whether there really was something wrong with me. If somebody thought that it was just, you know, depression, or it wasn't, you know, real, you just kind of have to meet somebody with ME and understand that they're desperate to live. All they want to do is get out and do things and live and, you know, work.
So before I go on too much further, hang on a minute. Oh dear, better go and sort that out. Sorry, apologies. We nearly got treated to the red carpet there with the James Bond. That would have been exciting. Are there any questions so far? Now we're sort of just past halfway.
Yeah, so thank you, Dr. Muirhead. We can pause there for a second and just give participants time to maybe put a few questions into the Q&A.
If not, I shall carry on, but it'll prompt people to think of some, so that's great.
That's great. So please, yeah, continue to put your questions in there, and we'll obviously hold them to the end of the presentation. Thank you.
So what really needs to happen is none of this sort of meeting in the middle or compromising or saying, well, if you try and do this, you know, I'll try and support you. What needs to happen is, as healthcare professionals, we need to completely get rid of all our preconceptions, because there has been quite a lot of stigma attached to ME/CFS in the past. And we have to just think, okay, what is this patient telling me? Believe what they're saying, and then try and work with them to try and help support them. And this is contribution from Asad, our long COVID doctor, and he has exactly the same message. Listen to your patient. No, really listen to your patient. It's okay not to know what's wrong, and it's okay to admit that. Just acknowledge their suffering and show empathy. Exclude serious pathology and keep your mind open to that. And in the absence of guidelines, which aren't sort of really finalised for long COVID, and there's very few randomised controlled trials yet, offer symptomatic treatment. Don't dismiss your patient's ideas about diagnosis and treatment. They may know more than you, because that's all they want to do. They want to get better. Form a partnership with your patients. The tests are normal does not equate to it's medically unexplained or all in your head. That's lazy medicine. Look harder. They may not be available, the tests that you need, but there's plenty of evidence now in the literature which shows significant differences, biomedical, physiological, energy delivery, metabolomics, mRNA. There's so much difference between ME/CFS and healthy controls, and I'm sure they will start finding similar differences with some of these long COVID patients who are the subset who are having the same ME/CFS constellation of symptoms. So we need to all look harder, and we need to be scientific. Do not project your uncertainty onto the patients or label them as anxious. There's a difference between legitimate worry about one's illness and disproportionate anxiety. Unexplained tachycardia in the middle of a pandemic with a new virus is not necessarily driven by anxiety. Lots of people are anxious, but they're not getting these multi-system symptoms which cause them to have a significant impact on their quality of life, so they can't do anything. That's not anxiety. And with a possible couple of million long COVID sufferers in the UK, this is every doctor's problem. I think most will start to recover, but I think there will be a significant subset, tens of thousands of patients, and perhaps 5,000 or 10,000 patients in Ireland with long COVID or new onset ME/CFS following the pandemic. So lots of patients, lots of people whose lives are missing. So back to ME/CFS, because we don't have the epidemiological statistics about long COVID yet, but it does seem to be emerging that it is more female than male, and most seem to have sort of other comorbidities, autoimmune conditions, commoner in ethnic minorities. So there are some similarities coming through, but we need more studies on a larger scale. But for ME/CFS, there's a female preponderance, a bit like multiple sclerosis and other autoimmune disease. Tends to peak in adolescence and middle age, often triggered by a viral infection. Life expectancy for HIV and MS these days is only around 5 years shorter than normal. Life expectancy for ME/CFS, there's been very little studies on it, very poor quality studies, and one estimates that it's 17.5 years shorter than normal. And it would be nice to have more literature to find out if that's the case and why. Patients tend to like to be referred to as having ME or myalgic encephalomyelitis to reflect the myalgic, the pain, and the encephalomyelitis, the inflammation of the brain and spinal cord. Chronic fatigue or chronic fatigue syndrome seem rather weak descriptors of the illness. Someone has likened it to calling Alzheimer's chronic forgetfulness. It tends to minimize the issue, that the serious medical condition that it is. Diagnostic criteria have been evolving over the last few years, and the latest include the 4 main cardinal symptoms: impaired function associated with fatigue lasting 3 to 6 months or more, post-exertional malaise, this is the symptom exacerbation after physical, mental, or emotional exertion, unrefreshing sleep, and that can include things like having a lot of dreams, waking up feeling tireder than the night before, difficulty going to sleep, so feeling tired and wired, tapping into adrenaline just to get through the day, and then by the time you go to bed, you're overtired, overstimulated. And cognitive impairment. In the US IOM criteria, orthostatic intolerance and cognitive impairment can be interchanged, so it's cognitive impairment or orthostatic intolerance. Orthostatic intolerance is picked up in around 80% of patients, and symptomatic in perhaps only maybe 50 to 70%. So it isn't part of the main diagnostic criteria that NICE suggested in their draft, but it is one of the key symptoms, and it should be tested for when the patient attends. Other features are this atypical chest pain, shortness of breath, headaches, unrefreshing sleep, flu-like symptoms, memory and concentration problems, and muscular, tendon and joint pain, and even deep bone pain. What's really interesting, I keep coming back to long COVID, but again, the top symptoms of collected on an online survey were fatigue, relapses, so this worsening, fluctuating condition, chest pains, headaches, shortness of breath, GI symptoms, very, very similar list. And it's this huge long list of multi-system symptoms that seems to be repeating and repeating with every patient that presents, including irritable bowel, sore throat, dizziness, anxiety, atypical depression, sensations of altered temperature, exertion-induced cognitive dysfunction, irritant sensitivities, and feverishness. Patients with ME/CFS can often look very normal and behave very normally in the first 10-minute consultation. And this test, which was done in 2017, showed that when ME/CFS patients did simple math sums compared to controls, they were just as accurate, just as intelligent, just as good as answering the questions. But as you can see from the red bars, the more times they did the test, ME/CFS patients actually made more and more errors. And that's because their brains were getting fatigued. And when they scanned the brains, patients were trying to use lots of different areas of their brain to access the answers. Whereas controls became more and more accurate the more times they did the maths test. Yes, but not enough and not large enough. And one of the issues has been the diagnostic criteria, who to include. So some of the earlier ones have included quite a wide range of patients, some with ME/CFS and all the neurological symptoms and post-exertional malaise, but others have been slightly broader using the Oxford criteria. And so that involves quite a lot of fatigue patients who would perhaps get better with things like exercise and cognitive behavioural therapy. So the diagnostic criteria is actually quite important. So more needs to be done. There was a really good randomised controlled trial on immunoglobulins, which has not been really shared in the literature, but more needs to be done with blinding and double blinding. There was another one with rituximab in Norway, which showed no significant difference between rituximab and placebo, but the placebo was a saline drip, which was actually very helpful for postural tachycardia and dysautonomia. And there do seem to be subsets within ME/CFS. So there may be responders and non-responders. And because they've all been put in one group to look at the data and it's all been blinded, then it's very difficult to tease apart. But for those who did get better with the treatment, they have had a huge difference to their quality of life. And what would be really nice in the future would be to see if genome information or sort of tailor-made medical choices, depending on your family history or genetic predisposition, could be chosen to help make sure you're a responder to whichever treatment. So I think with the advances now in medicine, this will get better. Patients have to accept that they're not well, and that can be really difficult. And I think that has been one of the biggest challenges for me personally, but I think is shared by many other patients as well. We all just want to have a normal life and get on with it. And it's part of our sort of mental well-being to have control. So to not have control over your energy levels feels frustrating. And it was only by pulling back and doing a lot less that I was able to find out how I could cope better. But you do go through emotion and grief, accepting the diagnosis. You need support of friends, family, GP, healthcare professionals to acknowledge how sick you really are. And some days you will feel a little bit normal and then you'll think, am I a fraud? And that is really, really difficult. And it's really difficult on the mental health, because then you'll probably overdo it and the next day you'll be back in bed again. And so encouraging a patient to do less may be helped by involving friends and family and other supporters, may be helped by doing a sort of activity diaries. Some patients are too sick. I was too sick to begin with to do anything like that. But really saying, whatever you think you can do about half. And then once you've rested and managed that, then we'll have another conversation as to how much that actually is and how you're coping. Post-exertional malaise, what to ask the patient. How many hours a day can you function productively? And what fraction of your pre-illness capacity are you functioning at? And that can help sort of discern how much the person can actually do. And by asking that question, it may prompt them to realise or recognise how little they really can do on on a good day. You can ask them on a good day and on a bad day, what can you manage? And what happens if you do something like you normally would have done before? And how much activity does it take for you to feel ill? Some people are feeling ill all the time, and they rarely get a day of feeling anywhere near normal. And do you avoid or change certain activities? Because what happens after you do them? So this is the horrible slide that I mentioned. And it is very important because these are all the associated illnesses that go sort of hand in hand with ME/CFS and should be sort of asked as part of the systems inquiry. Are they getting postural tachycardia? Measure it. Do a home standing blood pressure and heart rate every minute for 10 minutes with them standing or leaning against a wall. Do they have a past or family history of fibromyalgia, connective tissue disorders? What else is going on in terms of small fiber neuropathy, mast cell activation syndrome, allergies? A lot of patients who are also getting restless leg. It is very depressing to be fully fit and well, have a virus, and then be a fraction of your pre-illness capacity. So a lot of patients will get secondary anxiety or depression. Anxiety because going to the corner shop can be like doing a full-on Ironman triathlon in terms of the physiological reserve that is required. And if you've forgotten something and have to do it all over again, that would make you very anxious. And people will become depressed. They've lost who they were or who they thought they were, and all their goals and ambitions. You can't plan holidays, or it's very, very difficult to adjust to having a chronic illness. So some patients will need support, but if they do need antidepressants, then start low and go slow, because they can sometimes affect energy levels, which can even make the person worse. And there are lots of gynecological disorders associated with ME/CFS and fibromyalgia. There seems to be a bit of a triad with endometriosis as well. So Ehlers-Danlos can be picked up on a Baton score. There is some controversy in the literature how accurate and helpful this is, but I think it should be at least thought about and documented. And investigations include the orthostatic intolerance, lying and standing blood pressure and heart rate. And if there are focal neurological signs, of course, send the patient for an MRI scan to rule out space-occupying lesions or MS. ME/CFS can also be a differential diagnosis for many other disorders, including Lyme disease, viral illnesses. Please be aware that sleep apnea can cause some of the fatigue and unrefreshing sleep problems, and actually might be something that the patient has and they don't even have ME/CFS at all. So do be aware there are other differentials that mean you can rule out ME/CFS. Take a good history, make a diagnosis, consider this patient sick. They've got immune and neurological compromise, they need flu jabs, they need COVID booster shots. They're vulnerable, they may not be able to concentrate very well, they may not be able to communicate very well. Arrange suitable, regular, appropriate follow-up. I think at least yearly for GPs in the community, face-to-face. Exercise is harmful because at a cellular level, patient fitness does not improve from one day to the next. Repeat cardiopulmonary exercise testing shows that objective parameters such as VO2 max and lactate get worse the next day compared to healthy controls, which is well summarized in a lot of the literature, and they're repeating this now on long COVID and having similar findings in the subset who are getting post-exertional malaise. there seems to be a problem with the use of oxygen by muscles from when treated with ME/CFS plasma. And patients report, I'm just keeping an eye on the time because we're coming to the end, patients are reporting that they're getting worse with exercise rather than better. All healthcare professionals, it doesn't matter if you're a healthcare assistant, a social worker, a physio, nurse, OT, listen to and believe in your patient, provide compassionate care, recognition and support. Oh, and then this is a very exciting bit of information about some yet to be published research that we've recently done on 1,418 patients and their family members, showing that the impact of ME/CFS on the quality of life of family members is huge, and it's statistically significantly larger than either long COVID in the early stages. I think the long COVID research needs repeating now that patients have been ill for more than a year, some of them, and significantly worse than cancer. Here, a higher score shows greater impact on quality of life of the family member as well. This is hugely impacting our society. There are lots of medical interventions, and I will produce this as a handout for any doctors who would like some guidelines. I think we'll leave it there.